With me I have Dr. Alan Gora, an emergency medicine physician at Mount Carmel. So Dr. Gora, can you please tell me what you do on a regular basis in your line of work?
So I'm an emergency medicine physician. I work in the emergency department, which sees a variety of different things from traumatic injuries to medical illnesses to psychiatric emergencies. We pretty much see everything.
Yeah, so a wide variety. Can you explain what an opioid is, real quick?
Yeah, it's traditionally has been used to help control pain. Obviously, it's what's gotten us into trouble in the place that we're at now because we misunderstood the effects and the physical dependency and addiction possibilities associated with the medication. So it's a medicine that helps control pain. Associated with it is also a sense of euphoria that patients can see, and that's where we really got into trouble, not only with the pain management piece of it, but the euphoria characteristics that are associated with opioids as well.
Right, and that's where you get, commonly the illegal drugs like heroin and
Correct.
Like your illegal fentanyl and stuff.
Yep.
So in your line of work, what are some conditions, injuries, things like that you might prescribe opioids for?
Currently, it's a little bit different than it was 20 years ago. 20 years ago, we had an opioid-centric pain management process. So whether you came in with a toothache or an ankle sprain or whatever kind of pain you had, it was opioid-centric. Recognizing the trouble that we got into, we're now looking at minimizing opioids and using other pain management modalities. So I try to limit currently opioid use for those more moderate to severe pain, acute injuries, fractures, acute surgical emergencies, and for people who have more minor, less debilitating pain, simple ankle sprains, sore throats, muscle strains. We're trying to use a multimodal approach where we use things like anti-inflammatories, Motrin, Advil, ibuprofen. We use Tylenol. We use heat and ice again as strong encouragements to help manage people's pain.
And do you still see some physicians prescribe opioids for some of the more minor things like your ankle sprains and your everyday injuries?
I do, certainly a lot less so than we did before, but there certainly has been a change in prescribing practices. Fortunately for us, on the other side of the coin, as patients are recognizing the challenges that you can get into by prescribing opioids. So in patients who I say who may even have more moderate or severe pain, they sometimes want to avoid the opioids. Unfortunately, there's still a patient population that will say, that stuff doesn't work for me, meaning Motrin, Advil, Tylenol. No, that stuff doesn't do anything for me. I need something stronger. And as a provider, as a physician, sometimes they will accommodate that request. But generally speaking, the trend has been moving away from opioids, and if you do need to use them for more severe pain, it's certainly for only short term.
Okay, so what patient-related or workplace-related factors might lead a physician to prescribe more than they normally would? More like opioids, stronger medicine?
I think a lot of it has to do with patient expectations. Fortunately, we're changing the way that we look at managing pain. It's no longer controlling pain. Everybody has heard about the regulatory pain being the fifth vital sign back 20 some years ago, and how we felt obligated to control patients' pain, and how patients were educated to expect their pain to be controlled. So a lot of it has to do with patient expectation. We're responsible for making not only a quality relationship with our patient and providing good care, but somewhat unfortunately, we're also obligated to try to make the patient have a positive experience as they receive care. And so meeting patient expectations in our current environment are much more of an important thing for a provider. And I think it's that patient expectation of receiving a certain type of pain medicine for their pain when they've received it before, even though we're in a different environment, often makes people challenged and will let them write for those opioids in that setting.
Right. So like how would a patient satisfaction, like a pain satisfaction survey play into like what we have going on here with overprescribing?
Less so. I think we're coming around to it, but I will tell you early on, a lot of it had to do with patient satisfaction. And there's no doubt that patient satisfaction plays a role. I mean, there's studies that say satisfied patients recover better, they understand their illness better, they leave with a better understanding of things. But you can take it to the extreme of where we're obligated to make a patient's experience positive. And on the back end of that, there have been revenue changing processes that are set in place. So now reimbursement for care is somewhat related to whether or not a patient was comfortable with their care, whether they had a good experience, not whether they had quality of care, but whether they were satisfied with their experience. And some of that is still controlling their pain. People have been given the impression that their pain should be controlled. We can't always control pain. Pain is a normal process of healing. We can manage it, we can help you control it so you can regain function, but eliminating pain is just not an option.
So how might you, how might you describe that to a patient who, who might be leaning more towards like controlling pain as opposed to simply managing it?
Some get frustrated with that, but it's basically what we do when we prescribe any medication. It's educating them about risks and benefits. And all medication to some degree is poison depending on how much you take. So it's educating them about potential risks, including with opioids, physical dependence, fatigue, inability to kind of regain function more quickly. So it's educating them on the benefits of opioids, which in minor pain probably have more risk than they do benefit, and then educating them about why we're where we're at now, because there's physical dependence that actually develops with opioids. And we recognize that now, when in the past, we didn't think that that was true.
So what do you see of the dependence and the opioid addiction? Do you see instances of that come through in your line of work?
Every day, unfortunately. Some are blatantly obvious, where you have people that are now addicted to IV heroin when they started with prescription medications, and they ran out of their prescription medications and their source for prescription medicines, so they had to turn to IV heroin. So we see the people that are blatantly obvious, that are the true addicts, that have opioid use disorder, that come in as an overdose, that come in with associated complications of IV drug use. That's one patient population. And then we have another patient population that are diverting drugs. So they're coming in with a painful condition that may be feigned, and they're asking for prescriptions for opioids because they fell down the stairs or had a painful injury, and so they're going to take those and then they're going to divert those medications. And then finally we have people who are addicted, and they come in not open about their addiction, but they've been doctor shopping. You can look at their prescriptions over the last year and seen that they've got multiple opioid prescriptions from multiple different providers, yet they're not forthright with that. So, and then the final patient population are those people that are truly in pain and probably deserve to get some sort of opioid short term. And because of the pendulum shifting so far to really minimizing opioid use, there are patients that probably don't get short-term prescriptions for opioids when they really need it, because we're so afraid of actually creating another person who's physically dependent, or even worse, an addict.
Right, so it's a double-edged sword.
Yep.
So what impact do you think overprescribing has had on what's the breadth of the impact overall in the opioid epidemic in the United States?
I'm sure there's percentages out there, but there is no doubt that there's a good percentage of people who are addicted now on recreational opioids like heroin, who started out with a single prescription from a provider. There's no doubt that people started with a painful condition, they received opioids, maybe inappropriately, they became addicted after becoming physical dependent. That behavior led to them seeking pain medication prescriptions, and unfortunately, those medications now are no longer present for them, so they have to seek elsewhere for their addiction. And that's what transitions to the street drugs and the heroin and the fentanyl. So many of those, I can't give you an exact percentage, but many of those people start with prescription pain pills and then unfortunately decompensate into IV drug use and recreational drug use.
Yeah, so is the opioid epidemic, is that something that you commonly talk about with other physicians?
Yeah, we do. I mean, there's no doubt that the conversation has changed over the last 2 decades, and we will frequently converse at our workstation when someone will come in and say that they fell down 10 stairs and they don't have a scratch on them, and they'll say Motrin and Advil and ibuprofen and Tylenol don't work for me, I need something stronger. So we'll have that conversation. You know, for us, it's impossible to avoid it anymore. We have the Board of Pharmacy that monitors our opioid prescribing as individual physicians and gives us a report regularly in the state of Ohio about our prescribing practices.
And when did that start, out of curiosity?
It's got to be at least 5 years, it may be closer to a decade. So it's progressed, it's actually advanced. It was more of a challenge early on to get access to those prescriptions, but now I will get a report, or I can sign on to the Board of Pharmacy website and I can get a report and see what my opioid prescribing practices are.
Interesting. All right. Well, thank you very much,
You're welcome.
Dr. Gora.